Hello again, and welcome to set 7 of our internal medicine review questions. I'm not sure if you notice here, but we are now full screen. I updated my PowerPoint software, and now I guess I have the capability of doing this full screen, or maybe I did before and didn't know. But this is nice because now I'll be able to make the font a little bit bigger or cram more information into each slide. And so that hopefully will be more convenient for you to watch, or at least more pleasant. If you haven't gotten the opportunity yet, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. If you could consider chipping in $1 a month, a little bit goes a long way to help keep these videos free. As you know, I do work full-time, and putting these videos together does take time and energy. And so I really appreciate all the support I can get. If you subscribe, you'll have access to some of my premium videos, which are up there and available to subscribers. And I go over case studies and reviews and stuff like that. So thank you very much in advance. We'll start out with question 1. We have a 54-year-old man currently hospitalized for aspiration pneumonia. He has a relevant history of type 2 diabetes, gout, and alcoholism. He's currently on ampicillin and gentamicin. Home meds include allopurinol and metformin. On day 5 of treatment, he remains febrile at 100.6 degrees Fahrenheit. Blood pressure 98/65, heart rate 105, respirations 20. Which of the following is the most likely explanation of this patient's renal failure? A. Toxicity from ampicillin. B. Toxicity from gentamicin. C. Toxicity from allopurinol. D. Hyperuricemia. E. Sepsis. Or F. Hypovolemia. Okay, so here's his metabolic panel and his urinalysis. That might be important for you. USMLE will often give you this. Sometimes not, but often we'll give it to you. It's not always useful, but most of the time it is. So here it is for you. So take a look at that, and you can pause if you want. All right, I got a fly here in my office, and so if you hear this buzzing sound, or if you hear me trying to slap myself, trying to get the fly off me, that's what it is. All right, so the answer here is B, toxicity from gentamicin. So what is gentamicin? Gentamicin is an aminoglycoside. Aminoglycosides are poison for your kidneys. Now, for most people, they get on just fine, but some people are sensitive to it, and this guy, unfortunately, has renal failure from the gentamicin. How do we know that? Well, what kind of renal failure do aminoglycosides cause? It causes acute tubular necrosis. And what does acute tubular necrosis look like? Aside from the fact that it gives you renal failure, which we see here with the BUN creatinine levels up. You see that. Anytime you see a creatinine level like that, alarm bell should be going off. So you know he's got renal failure. But how do you know he's got acute tubular necrosis? Pigmented granular casts. That's the fancy name for it. But what's the not so fancy common name for pigmented granular casts that you've probably heard before? Muddy brown casts. Now, you might be told pigmented granular casts. They probably won't tell you muddy brown casts, or they might give you a picture of it. But you want to know that pigmented granular casts, or muddy brown casts, are acute tubular necrosis. These are bits and pieces of the tubules that have shed off, and they got blood all over it, and so now they've turned brown, and this is the muddy brown cast. So this is pathognomonic for acute tubular necrosis. At that point, you got to know which of these are going to be associated with acute tubular necrosis, and the only one really that's plausible in this scenario is the gentamicin. Now, hyperuricemia can cause acute tubular necrosis, but what makes us not think that this is caused from hyperuricemia? First of all, his uric acid level is really not all that high. In order to have acute tubular necrosis from hyperuricemia, you're going to probably see uric acid stones, but you'll also, you need to have a uric acid level that's really high, talking in the 20s and higher. So this is just not high enough for it to be caused from hyperuricemia. So we get rid of that. Does ampicillin cause renal issues? Yes, it does, but it does not cause acute tubular necrosis. Ampicillin causes acute interstitial nephritis, which is totally different. Acute interstitial nephritis is a problem of the interstitium of the kidneys, whereas acute tubular necrosis is a problem of the tubules. So acute interstitial nephritis is going to cause some white blood cells in the urine, and those are going to be eosinophils, because acute interstitial nephritis is really an allergic sort of reaction. So with acute interstitial nephritis, you can get like fever and rash, and eosinophilia in your blood, and then eosinophils in the urine. So you'd have a positive white blood cells, and you look at the white blood cells, and it turns out they're eosinophils in the urine. That would then be from the ampicillin. But that's not what we have here. We have pigmented granular casts. So ampicillin out. Why not allopurinol? Does allopurinol cause renal issues? Really, no. Allopurinol causes a rash. It can cause vasculitis in rare cases. Sometimes it can cause a drug-induced hepatitis, but it does not cause renal issues. Sepsis and hypovolemia, they kind of both fit under the same picture. They both they can cause renal issues, but it's going to be a pre-renal failure. And how do we know that this is not pre-renal failure? And this is what I really want to get to in this question. It's the very first thing you should ever do anytime you have a patient with new onset high creatinine. The very first thing, it should be a reflex. The very first thing you should do is look at the BUN ratio, look at the creatinine, and divide it. You want to get the BUN creatinine ratio. Now you can express this as a number to another number, so like 9 to 1 or 12 to 1 or 15 to 1. I just divide it and get that important number, the first number. And so you take the BUN, divide it by the creatinine, you get 8.6. And that number is going to be very important. So the BUN creatinine ratio should always be calculated when the creatinine is elevated and there's reason to suspect acute kidney injury. The important numbers here are 10 and 20. So if the BUN creatinine ratio is higher than 20, that suggests pre-renal failure. Now, why would pre-renal failure give you a BUN creatinine ratio that's high, over 20 to 1? So when you have pre-renal failure, it's usually due to like a hypovolemia or a poorly perfused kidney, either from sepsis because your vessels are expanding and you're not perfusing the kidney properly, or because you're dehydrated, something like that. Kidney's not being perfused properly. What the kidney senses is that you don't have enough water. In any case, if the kidney's not perfused properly, your kidney's thinking, I must not have enough fluid because not enough blood is getting brought to me, so that's what your kidney thinks. So if your kidney doesn't think you have enough fluid, it's going to try to reabsorb as much water as possible. And when it reabsorbs water, it's going to bring in sodium and it's going to bring in BUN. So you're going to be reabsorbing BUN like crazy. And so what's going to happen to your BUN level? Your BUN level is going to go up really high. Even though your creatinine ratios, your creatinine is also going up, your BUN is going up much, much, much faster. And so your BUN to creatinine is going to go up. Even though they both go up, your BUN is going to go up faster because you're reabsorbing it with all that water that your kidney's just so avidly reabsorbing. Now, if your BUN creatinine ratio is less than 10 to 1, then we suspect intrinsic renal failure. And the reason here is because you have kind of the opposite problem. Your kidney is, with intrinsic renal failure, the problem is with your kidney, right? So your kidney is not able to reabsorb that water, not able to reabsorb that BUN. So your BUN is going to be a little bit lower, but your creatinine is going to go up, just like it did with pre-renal failure. And so your BUN stays kind of lower, and your creatinine goes up, and so that causes a lower ratio. So more than 20 pre-renal, less than 10 intrinsic. If it's 10 to 20 in that kind of normal range, then you don't really know. Post-renal failure can fall into this category, but post-renal failure is usually pretty evident clinically. Really enlarged prostate, a stone in the distal urinary tract, bilateral stones. So usually that's pretty evident clinically. But the ones you really want to know, greater than 20 pre-renal, less than 10 intrinsic renal. The BUN creatinine ratio is meant to be a guide. It is not diagnostic by any means. Even if you do use it to try diagnose, it just gives you a category. It doesn't tell you what the diagnosis is. So it's really just a guide. You always need to consider the entire clinical picture, other labs, etc. And obviously, in this case, we have a very important lab, the urinalysis, showing pigmented granular casts. Do you even need to do the BUN creatinine ratio? Probably not, because you kind of have the answer right here. But you should always do it. It should just be a reflex, because it's going to tell you what category this patient's renal failure falls into, and that's really helpful. Another way that we can do this, a little bit less commonly done, the nephrologists like it, you should know it for the test, at least how to calculate it, is the fractional excretion of sodium. You want to know what this means. So the fractional excretion of sodium is just a big mathematical formula. So all you're doing is you're taking the sodium concentration in the urine times the serum creatinine and dividing it by the opposite. The serum concentration of sodium times the urine concentration of creatinine. So you divide those and you wind up with a percentage because you're multiplying this by 100. And so this percentage then gives you an idea of what the cause might be. So let's say you have pre-renal failure, you have poorly perfused kidneys. What did we say the kidneys do if they're poorly perfused? They reabsorb water. They're pulling water back in. If you're pulling water back in, what are you also pulling back in? You have to pull in sodium because that sodium drives the water coming with it. So if you're dehydrated, you're pulling water in, you're pulling sodium in, what do you think happens to your excretion of sodium? So this is fractional excretion of sodium. How much sodium that goes to our kidneys is leaving in the urine. Well, if you're reabsorbing water and sodium, your fractional excretion of sodium is going to go down because you're excreting less sodium. So the kidneys in this case are functioning properly. They're reabsorbing water because they're underperfused. They're reabsorbing sodium. And so pre-renal failure is going to be a low fractional excretion of sodium, less than 1%. Now, the cutoff for intrinsic renal failure is, they disagree, 2 to 3%. I imagine the USMLE, if they give you a fractional excretion of sodium that they want you to link to an intrinsic renal failure case, it'll be high. It'll be like 3.8 or something like that. So if you have a high fractional excretion of sodium, what that's telling you is that you're wasting sodium. You're not reabsorbing the sodium you need to reabsorb. And so if you're wasting sodium, then your fractional excretion of sodium is going to be high. And usually this is due to damaged tubules, or you're just spilling too much sodium out in your glomerulus to begin with. But usually it's due to damaged tubules. And that impairs your reabsorption. You're going to have more sodium in your urine. So that is a high fractional excretion of sodium, and that is intrinsic renal failure. And that makes sense, because if your kidney's not working, your tubules aren't working, or the channels aren't working, you're not reabsorbing sodium as you should. All right, so aminoglycoside toxicity. That was the problem with this patient. Now, aminoglycoside toxicity, you should think of two things: ototoxicity and nephrotoxicity. We talked about the nephrotoxicity that causes acute tubular necrosis, but the other one you want to think of is ototoxicity with aminoglycosides. And ototoxicity here, we're talking about the vestibulocochlear nerve, that CN8. And because it has two branches, two functions, it can cause two different sets of symptoms. So the cochlear part, which is going to be your hearing, that gets damaged, you have hearing loss. The vestibular part, if that gets damaged, of course, you're going to have dizziness. So hearing loss and dizziness can come with aminoglycoside toxicity. So you should remember those two for the test. So they're the most well-known adverse effects of aminoglycosides. The other one is neurotoxicity, but it can kind of be hard to tease out some of those symptoms because they look a lot like the vestibular symptoms. So that one I wouldn't be as concerned with. Gentamicin is the most nephrotoxic of the aminoglycosides, but remember, you have all sorts of aminoglycosides, but gentamicin is the most nephrotoxic. The toxicity usually manifests after 5 to 7 days of treatment, which is often, we need to at least have that amount of treatment. So anytime you give aminoglycosides, you run the risk of nephrotoxicity. There are risk factors that increase your risk of getting toxicity from aminoglycosides. So older patients who already have poor renal function, if they have a higher dosage or a split dosage, in general, I'm not a pharmacist, but my experience has been that it's better to give aminoglycosides in one daily dose, even if it's a little bit higher, than to constantly be bathing those kidneys in more frequent dosings, even if those dosages are lower. And then things like dehydration, obviously bad for the kidneys. Longer treatment duration for obvious reasons. Hepatic dysfunction, metabolic acidosis, and then concomitant therapies with other potentially nephrotoxic drugs. Okay, question 2. We have a 60-year-old woman presenting complaining of intermittent blurred and darkened vision in her left eye over the past week. She says that the episodes come on out of nowhere and they resolve spontaneously. The vision loss always starts from the top and goes downward. She can't name anything that causes the episodes. She denies other symptoms, including headache, nausea, vomiting, or eye pain. Her past medical history includes hypertension and type 2 diabetes, which is controlled with lisinopril and metformin. but she has not seen her optometrist in 2 years, at least 2 years. Vitals are within normal limits. Physical exam is unremarkable. Cranial nerves 2 through 12 are intact. No focal deficits. Conjunctiva pink. Sclera clear. Pupils are equally reactive and responsive to light and accommodation. There is no pain in either eye. What is the most likely cause? I didn't put it here, but what's the most likely cause of this patient's symptoms? A, diabetic retinopathy. B, retinal artery occlusion. C, retinal vein occlusion. D, amaurosis fugax. Or E, retinal detachment. All right, so our answer here is amaurosis fugax. Now, amaurosis fugax is one of those things that it's not really a diagnosis, but it's more of a symptom, but it's one of those symptoms that's just so prominent that it's kind of a diagnosis. So I hate to say that this is the diagnosis in this patient. Really, the more appropriate diagnosis would be probably would be that she's got bad arteries. She's probably got some issues with atherosclerosis. But amaurosis fugax does come up on the test. They do want you to know about this entity, so that's why I brought it up here, at least so that we could drive home this topic. So amaurosis fugax is really just, it's kind of the way you can think about it, and I don't know if this is the best way to think about it, but to me it helps and it's sufficient, is it's angina of the eye. So what's happening with amaurosis fugax is that you have a slight blockage going. You have a slight blockage of blood going to your eye, and so your eye becomes somewhat ischemic, I guess you can call it. And so because you're not getting enough circulation, obviously the organ's not going to function as it should, but instead of getting pain as you would in your heart, you get a visual deficit. And it's kind of so amaurosis fugax can, people who have episodes of amaurosis fugax are predisposed to ultimately develop retinal artery occlusion. And retinal artery occlusion is kind of like a heart attack of the eye. It's like an MI of the eye. So retinal artery occlusion, it's very similar in pathophysiology. So remember, amaurosis fugax is usually due to a spontaneous atherosclerotic embolism into the eye circulation. But then that goes away, right? So it goes away, and then you're fine. With a retinal artery occlusion, you have a full-on blockage, and it does not go away. And so retinal artery occlusion is more of like a heart attack of the eye. So with a retinal artery occlusion, you'll have a sudden, profound visual loss, very similar to the amaurosis fugax episode, but that episode does not spontaneously resolve. It continues, and these patients can go blind from that, just like you can die from a heart attack. You don't need your eye to survive, right? If your heart loses oxygen for too long, your heart gives out and you die. If your eye loses oxygen for too long, well, your retina will be fried, but you'll live. So what happens then is you just go blind in that eye. So the retinal artery occlusion, it seems like amaurosis fugax at first, but then it continues. It doesn't resolve spontaneously. And so if you were to look at retinal artery occlusion with a fundoscope, which we didn't do here because this patient came into the ER, but if you were to look at a retinal artery occlusion with a fundoscope, you would see a sort of a pale retina and a pale fundus, and then you see this little cherry red spot. It looks very different from a normal fundoscope. Now, on the other hand, diabetic retinopathy, why is that not the case in this patient? One very important reason that we already talked about, this is intermittent episodes. Diabetic retinopathy, like other diabetic complications, are chronic. So diabetic retinopathy it is the #1 cause of blindness, by the way, in the US in adults, but this is progressively blurring and darkened vision. So it's similar pattern of darkness, I guess you could say, to amaurosis fugax, but it's chronic. It starts very slowly and just gets worse and worse, and then ultimately they go blind. So just the pattern of these episodes is not consistent with diabetic retinopathy, even though she's a diabetic, and even though she's being a bad girl and not seeing her optometrist as she should be seeing an optometrist once a year. This is not diabetic retinopathy. She may have some diabetic retinopathy, but that's not the cause of these episodes. If you looked on fundoscope with diabetic retinopathy, you'll see cotton wool spots and flame hemorrhages. And if you want to know more about this, go back to my ophthalmology lectures. I talk about this a lot. That fly is back. So I talk about these in the ophthalmology lectures. Retinal vein occlusion is kind of along the same lines, follows a sort of subacute course, a little bit different from the artery occlusion in that a vein occlusion can be a lot less severe, whereas an artery occlusion is usually very severe, kind of an emergency. A vein occlusion might not be as severe. Again, you are going to see some issues on the fundoscope. You'll see some retinal hemorrhages and some optic disc edema. Again, that's really the only way you're going to be able to tell these apart. So I didn't give you fundoscopy here. I talk about this in the ophthalmology talk. So if you want to know more about retinal artery occlusion, retinal vein occlusion, diabetic retinopathy, and retinal detachment, I think I have a specific lecture for each of these. So you can go back there. And then retinal detachment. So again, this is something you will easily be able to tell on fundoscope, but this is not consistent with retinal detachment because retinal detachment will just go away on its own. Retinal detachment will come on and those symptoms will be present consistently. It doesn't just come on and go and come on and go and come on and go. Retinal detachment, what's happening is the retina is actually coming detached from its basement membrane, so to speak. And as it becomes detached, you get this sort of kind of like this curtain closing in, but it doesn't go away like amaurosis fugax. And if you look, and also with retinal detachment, a lot of times patients won't so much talk about darkening of their vision. They'll say they've got floaters. That's very common. And they might describe haziness and dark streaks, but that can be described with amaurosis fugax too. So look for floaters with retinal detachment. And it does come on suddenly, but it doesn't really go away, and it gets worse. So retinal detachment is very easy to tell on fundoscope. You can look up a picture, but you literally see the retina is coming unglued from where it's supposed to be attached. So that's retinal detachment. All of these, except for amaurosis fugax, they all come on and they don't really go away. Amaurosis fugax is the only one where you get little discrete episodes, and they usually only last for minutes. So this is just kind of summing up what we talked about here. Painless, temporary loss of vision in one eye. Very important, painless. So if it were painful loss of vision, you would think glaucoma. Glaucoma is usually painful. Amaurosis fugax, never painful. Usually it's due to embolic atherosclerotic plaques, but it can also be due to other things that can impede or interfere with the delivery of blood to your optic circulation. So hypercoagulability, vasospasm, and then other causes, including neurologic causes, can look like amaurosis fugax. Amaurosis fugax, remember, is a symptom. It's not really a diagnosis. So really, our diagnosis with this patient is atherosclerotic plaques in circulation that leads to the eye. But amaurosis fugax is what we call these symptoms, and you want to know about this phenomenon for the test. So usually due to atherosclerosis involving the carotid artery or any artery between the carotid artery and the retina. So that's ophthalmic, central retinal, or the ciliary arteries. Why is this important? So we're not worried about her going blind right now, but what is something that's really important that we know about this woman more than likely because she's having these episodes? She probably has atherosclerosis. And where is that atherosclerosis? It's in her carotid artery, probably. So what we probably want to do with this woman before she leaves is or at least want to schedule her for a carotid artery ultrasound. Because if that atherosclerosis is in the carotid artery, as it very well may be, then she is at significant risk for stroke. And that is deadly. So we want to detect this. This is more of remember, it is a symptom, but it is something you want to pick out because it can lead to all sorts of complications. She's at risk for a central retinal artery occlusion. She's at risk for possibly a stroke. So we need to work her up for that. And then in addition, we need to work her up for potential treatment. So this is all step 3 sort of stuff, but you need to know what else do we need to do for her. We're going to need to get a lipid panel. And then if that lipid panel comes out high, she needs to be put on statins and diet modification. So the amaurosis fugax, getting back to that, stereotypically described as a curtain coming down, and usually is coming down from the top over one eye, and it's always one eye, it's never both. The diagnosis is clinical. There's a high risk of atherosclerosis, so you want to work that up appropriately, like I said, lipid panels, etc. The management is going to be an ophthalmology referral to really nail down the diagnosis, make sure there's nothing else there. and then treat the underlying cause. All right, question 3. We have a 47-year-old alcoholic who presents to the clinic complaining of fatigue and generalized weakness over the last 2 weeks, despite getting adequate sleep. Vitals are within normal limits. Patient appears tired and disheveled, but physical exam is otherwise unremarkable. No focal neurologic deficits. CBC is unremarkable. BMP reveals hyponatremia and hypokalemia. Which of the following electrolyte levels is most likely to also be deficient? A, calcium, B, iodine, C, magnesium, D, iron, or E, manganese? All right, I'll give you some time to pause here. This is a very common question, and it's so common that you've probably seen it, so it's kind of easy. But it's very commonly missed in practice, for as easy as it is on paper. So the answer here is magnesium. And magnesium, when it is deficient, it doesn't itself cause problems. The big problem that magnesium deficiency would cause in and of itself is torsade de pointes, which can be deadly. It can cause a deadly cardiac arrhythmia. But itself, magnesium deficiency, other than that, is really not a huge issue. Where it can cause issues is that when you have a magnesium deficiency, it can cause deficiencies or disturbances in the other electrolytes. And that's what's happening here. This patient is deficient in magnesium, probably because he's an alcoholic, and that's causing a deficiency in his sodium and potassium, and that's what's causing his fatigue and generalized weakness. So you need to remember that about magnesium. Yes, magnesium deficiency can cause torsade de pointes, but magnesium deficiency more commonly is going to cause disturbances in the other electrolytes, and that usually will lead to the symptoms. So could this be from low calcium? Can that cause fatigue and generalized weakness? Usually no. Calcium deficiency is usually going to be tetany, paresthesias, dysrhythmias. Usually it's going to be I think it's a QT prolongation, and then petechiae and purpura. You can get fatigue and weakness from calcium excess, so hypercalcemia, but that's not what we have here. So this is asking what's likely to be deficient. If you had calcium deficiency, you're not going to have fatigue and generalized weakness. Yes, you can get some kind of stupor and somnolence and stuff from calcium excess, but that's not what's happening here. Iodine deficiency, what would that cause? Goiter. Does this patient have goiter? No, his physical exam was unremarkable, so that's not the cause. Yes, I suppose if you had iodine deficiency, you have low thyroid hormone levels, that might cause you to be a little slow and sluggish, but that's not the case in this patient because his exam was unremarkable. And if you had iodine deficiency enough to cause symptoms, you would definitely have the goiter. Iron deficiency. Can iron deficiency cause you to be fatigued and weak? Yes, absolutely. Is that what's happening in this patient? No, his CBC is unremarkable. Iron deficiency will cause an iron deficiency anemia. That would cause a low hemoglobin. That would show up on CBC. And then what about manganese? So manganese I only put in here because it sounds like magnesium and maybe that might slip you up. But manganese is really a micronutrient. It's only in very tiny amounts. And it is associated, it kind of looks like vitamin C deficiency in some ways, cause some skeletal issues and poor wound healing. But it's very rare because manganese is easy to get in your diet and you don't need very much of it. So manganese deficiency, very rare. I wouldn't worry about manganese for the USMLE really if I were you. So magnesium deficiency is what's going on in this patient. And magnesium deficiency, the people who are at risk for magnesium deficiency are going to be alcoholics, people who are starving themselves, so think of like, anorexics and bulimics, and then people with diarrhea or malabsorption. Also, you can see magnesium deficiency in people who are on loop or thiazide diuretics, and then certain antibiotics and chemotherapeutics. If you've got to remember a drug with magnesium deficiency, think of the diuretics. Okay, so question 4. You are working in the urgent care clinic this evening, and 7 people have presented with sudden non-bloody diarrhea, which has developed in the last few hours. So you got 7 patients on your hands now. All of them have non-bloody diarrhea, and it's all came on within the last few hours. Some of these patients complain of other symptoms, including abdominal pain, cramping, nausea, and vomiting. All of these patients, and this is why clinical history is important, they probably would have recognized each other in the waiting room, though. All of these patients had been at the same company picnic this afternoon where food was consumed that was left out throughout the day, as we do this time of year in the summer. all 7 patients consumed the creamed cucumbers. Now, are you going to ask what food? Probably, but really when that's important is if you got like 2 or 3 family members that come in at the same time. But you know that all patients consume the creamed cucumbers, and you're being told that. Which of the following is the most likely cause of this patient's symptoms? A. Clostridium botulinum, B. Campylobacter jejuni, C. E. coli O157H7, D. Shigella dysenteriae, E. Clostridium perfringens, or F. Staphylococcus aureus. All right. So this is a common question, especially on step 1 and step 2. I don't know step 3 so much, but step 1 and step 2, you got to know this. Okay, so this is asking you, it's telling you non-bloody diarrhea. So if you know, as you should, if you know your different causes, bacterial causes, I should say microbiologic causes of non-bloody diarrhea versus microbiologic causes of bloody diarrhea, you should be able to eliminate some right off the bat. So the answer here is Staph aureus, and what you can eliminate right off the bat is B, C, and D. Why can you eliminate Campylobacter, E. coli, and Shigella? So you can eliminate Campylobacter, E. coli, O157H7, and Shigella because these all cause bloody diarrhea. So immediately, these are all out. B, C, and D are out. Now you're left with A, E, and F. So Clostridium botulinum, what does that cause? What disease does that cause? There's a name for it. It's in the name of the species here. It causes botulism. And botulism is caused from a toxin that is in the contaminated food. And that toxin, though, is not only toxic to your GI tract, it's also toxic to your nerves. And so it causes a flaccid paralysis in addition to the diarrhea. So these patients don't have neurologic symptoms, so we don't suspect botulism here. So now we're really just down to Clostridium perfringens and Staph aureus. And really, it could be either. Clostridium perfringens tends to take a little bit longer to kick in, but really just hearing this clinical history and this if you take out what they ate, you don't really know, especially if you didn't know what they ate. So you really wouldn't know at this point. What it comes down to is what they ate. And you're told that they ate creamed cucumbers. Clostridium perfringens is usually, and you need to know this, is usually caused from meats and gravies, whereas Staph aureus is going to be stuff with cream in it. Yeah, so dairy-ish kind of foods like potato salad, creamed cucumbers, pastries with cream filling, macaroni, stuff like that. So that is going to be Staph aureus. So you'll want to know these food correlations, and I put some of these on here for you. I made this table for you. And so here's some of the big ones. Bacillus cereus, B cereus. This was, I didn't put that as an answer choice. This is commonly caused from reheated fried rice. So Chinese food. If the USMLE wants you to know about B cereus, they're going to tell you rice. This usually causes a rapid onset vomiting, which then progresses to diarrhea. So a little bit of a nuance for that one. Staph aureus, we talked about cream and dairy. Usually it comes on very fast, like within hours of consuming the food. A lot of times the people who are eating the food might still be together, and so they all have it at the same time. But that's rapid onset of diarrhea and vomiting. Clostridium botulinum is botulism. Usually that comes from improperly canned vegetables or fruits. So my grandma likes to can rhubarb, and I'm always on her to make sure she's doing it properly. Yeah, I've done this for 60 years. She's 93. But she's been doing it for a long time. She insists that she knows how to do it, and as far as I know, she doesn't cause anyone to get botulism. But it would be very easy to do if you don't can your vegetables properly, because Clostridium is all over in the soil. You get that into a bottle, and don't can it properly, you're going to get botulism really easily from that. So that's from canned vegetables that are improperly canned. Now you have those cans of vegetables you go buy at the store, and usually they should have that little pop on the top that I don't know what they call it, but it's if like when you open it, right? So you open like a can of like pickles or something, and you open it, it pops up on the top. And what that thing is there for is that if there's gas on the inside of the bottle, it will cause the top to pop up, so that if you press down, you'll notice that there's gas inside there. So that's what that's for. If you have like an expanded can, like a swollen can of vegetables, you don't want to eat that because that's botulism. Clostridium perfringens, like I said, meat and gravies, typically just diarrhea, no vomiting. ETEC. So ETEC also causes, this is E. coli, but it's not the EHEC E. coli, not the E. coli 157H7. This is just pure enterotoxigenic E. coli, ETEC. You want to know this one because this is the one that causes the traveler's diarrhea. Usually don't get it in the US. Usually you get this if you go down to Mexico or Guatemala or Brazil. My sister went down to Cancun, I think it was Cancun, back in March, and she wound up coming back. Sure enough, day home, she gets back, diarrhea. She's like, oh, I drank bottled water. Well, did you eat anything? Yeah, I had burrito with lettuce. Yeah, that lettuce was washed in water from down there. So, unfortunately, bad side effect from traveling. You got to make sure you're drinking bottled water and that you're, avoid the vegetables down there. So that is traveler's diarrhea. Usually comes on relatively quickly, but sometimes not until after you get home. It could be when you're on the plane. Could you imagine how awful that would be? Ugh. Giardiasis, Giardia lamblia. Typically, this is camping and stream water. So you're camping out in a remote area, you're drinking water from the river. Classic setup for giardiasis. Usually these patients, yes, the diarrhea is bad, but what they more complain about is it's severe bloating and flatulence. So that's giardiasis. If you get an ova and parasites, which you should always do if you don't really know what the cause of the diarrhea is and you think it might be important, you get your stool lactoferrin and get your ova and parasites. The ova and parasites will come back positive because giardia is a parasite. Vibrio cholera, this causes cholera. And cholera is not common in the US, so it's unlikely to come up on step 2 or 3. This is a very, very watery diarrhea and usually caused from areas with poor sanitation. But such a watery, voluminous diarrhea, these patients can dehydrate very, very, very quickly. Cryptosporidium and Isospora belli, again, not likely to come up on step 2 or 3. These are only seen in AIDS patients. Important here, if you're taking step 1, you want to know these are acid fast and they will come up as a positive ova and parasite. Rotavirus, kids with rotavirus. Number 1 cause of diarrhea in kids. So it should be the first thing you think of. Very easy to transmit. Kids, sticking their fingers in their buttholes and then onto their toys and then giving those toys to other kids just spreads like wildfire in daycare. So that's rotavirus. Norovirus is the one that you always see on cruise ships. So norovirus, also known as Norwalk virus, and the maxim is if they can walk, it's probably Norwalk. So viral diarrhea in adults, usually norovirus. Viral diarrhea in small children, like a year or 2 old, probably more rotavirus. If you have an infant with diarrhea, just mild diarrhea, no other symptoms, probably rotavirus. So what about the bloody diarrheas? So the ones you want to remember for sure are Salmonella, Shigella, and Campylobacter, and then E. coli 157H7. So Salmonella and Shigella are very hard to tell apart. They're pretty much, and Campylobacter for that matter, they're pretty much caused by the same things. So it's hard to tell them apart. If they're going to ask you specifically to know Salmonella versus Shigella versus Campylobacter, what they'll probably tell you with Salmonella is contact with turtles. I don't know anyone with a pet turtle. Maybe you do. But you'll want to know that because it's very specific. Turtles have a lot of Salmonella on them. So if you have pet turtles, you're at risk for Salmonella poisoning, Salmonellosis. And so that may come up on the test. Shigella, really nothing there. Poultry, eggs, and milk. Campylobacter, usually poultry and milk. The big one here is that they are at risk for a subsequent Guillain-Barré syndrome. So the USMLE, a lot of times the way they'll pose that to you is you have a patient with Guillain-Barré syndrome, or all the symptoms of it at least, the ascending paralysis and so forth. And then it tells you that 3 weeks ago they had an episode of diarrhea which resolved on its own. And then they're going to ask you which of the following pathogens or bacteria is the most likely cause of this patient's presentation. And you might just think, oh, Guillain-Barré syndrome. Bacteria causes Guillain-Barré syndrome? No, not directly. But it can cause the diarrhea and the immune response to that pathogen being there, which can then in turn cause Guillain-Barré syndrome. We're not exactly sure the mechanisms behind that, but you'll want to know the link between Campylobacter and Guillain-Barré syndrome. That can come up. Yersinia, this really looks a lot, like the other ones as far as bloody diarrhea, but it also can cause a lymphadenopathy. And Yersinia is also more tightly tied to pork, whereas the other ones are more tightly tied to poultry. EHEC is the enterohemorrhagic E. coli. In its name, hemorrhagic, causes the bloody diarrhea. What you want to know with E. coli O157H7, which is included in the EHEC, is hemolytic uremic syndrome as a potential sequelae of this bloody diarrhea. Very, very, very important. And I'm not going to get into what hemolytic uremic syndrome is, but you can go back and look that up. You want to know the correlation between O157H7 and hemolytic uremic syndrome. Very important that you not give antibiotics. Even though this is an infection, you give antibiotics, you're going to worsen the risk for hemolytic uremic syndrome or the patient's course. Entamoeba histolytica we do not see in the U.S. hardly at all because it's due to poor sanitation. So bloody diarrhea acquired outside the U.S., you want to think of this, and there are various labs you can do to detect Entamoeba histolytica. And then the Vibrio parahemolyticus and Vibrio vulnificus are associated with shellfish. Vibrio vulnificus, I have seen one case in my life associated with diarrhea. The other thing that Vibrio vulnificus can cause, people who go out into like brackish water and like go to get, oysters or whatever, if that gets into their skin, it can cause necrotizing fasciitis. But if you ingest these, it causes diarrhea. And usually you get this from shellfish, oysters, clams, shrimp. Like I said, in that sort of brackish, usually fresh water is where Vibrio live. There was a case down in Texas not too long ago of a Vibrio vulnificus necrotizing fasciitis. Unfortunately, I believe she died. Oh, so I just went to Germany last month and ordered this platter. I didn't exactly know what I was ordering, but among these things was potato salad. I'm not a potato salad fan. As a matter of fact, I think I've tried it once when I was a little kid and didn't like it, but they brought out this potato salad, and of course the first thing my mind goes to when I see potato salad, being the nerdy doctor that I am, is Staph aureus food poisoning. I did eat it. It actually was pretty good. I will say my taste maybe have changed since I was a little kid, but yeah, that was the first thing I was thinking of. This food was all right, but I don't know. I think I prefer the Bavarian German food this was in Berlin, over the northern German food. But anyway, good food. All right, question 5. We have a 72-year-old man with a history of hypertension, congestive heart failure, COPD, and type 2 diabetes, presenting to the ER for left calf pain. Physical exam reveals a markedly swollen and painful left calf. Duplex ultrasound reveals a DVT in the left perineal vein. Heparin is started and the patient is admitted. His medication list includes insulin glargine once per day, insulin lispro before meals, furosemide, metoprolol, lisinopril, fluticasone, salmeterol, and a multivitamin. This guy is a pharmacy. On routine laboratory examinations, it is found that his potassium level is 6.2 milliequivalents per liter, which is slightly elevated. Which of the following medications is most important to discontinue at this time? A. Lisinopril, B. Furosemide, C. Metoprolol, D. Fluticasone salmeterol, E. Insulin glargine, or F. Insulin lispro. So this requires you to know what each of these drugs can do to your potassium level. Okay, so obviously the reason we need to discontinue a drug is the reason there's something wrong in this patient. What's wrong in this patient? Well, he's got DVT, but none of these things are going to cause you to get a DVT. And quitting none of them is not going to make the DVT go away. The only thing that's going to make the DVT go away is going to be the heparin. So the other thing is potassium level is high. And you know that these drugs all can kind of monkey around with your electrolyte levels to some degree. So what's the one that is, and you can pause here if you don't want my discussion about this yet. What's the only one here that's really going to make your potassium level high? So the only one that's going to make your potassium level high really is lisinopril. Now there's other ones here that are going to make it go low. What ones will make it go low? Will furosemide make your potassium level low? Of course it will. So furosemide, what kind of drug is that? It's a loop diuretic, and loop diuretics work on the sodium-potassium chloride pump. And if you block that pump, you block reabsorption of potassium. The sodium will get slightly reabsorbed later on, but that potassium is going to get wasted out. And so that's going to cause your potassium to go down. Furosemide is a loop diuretic, also works on a sodium-potassium chloride pump on the macula densa, which stimulates a slight increase in renin. And if renin goes up, aldosterone goes up. And if aldosterone goes up, it's going to be all the more potassium wasting because aldosterone pulls in sodium at the expense of potassium. So furosemide would cause a hypokalemia, if anything. Metoprolol, this I included it in here because I wanted to point out that, there are some, it's probably negligible, but it can cause a mild hyperkalemia. But what I want you to know, because if you do enough reading, you'll probably run into an article or two that says metoprolol can cause hyperkalemia. And the fact is, it can cause a slight uptick in your potassium level. And but I mean, metoprolol being a beta blocker, what it can do is inhibit renin release, which would then lower your aldosterone, and then that can cause your potassium level to go up. But it's probably so minimal that even if you stopped the metoprolol, his potassium level would probably still be high. Lisinopril is simply a better drug to stop because lisinopril, being an ACE inhibitor, it is going to drastically reduce your level of aldosterone, and that's going to reduce the amount of potassium you kick out, and so it's going to preserve your body potassium and cause a hyperkalemia. So metoprolol, I just wanted to put it in here because I wanted to contrast these two drugs that one of them might cause a little uptick in your potassium. The other one is really, we're worried about hyperkalemia as a side effect, and that's always something you need to consider when you're giving an ACE inhibitor. So metoprolol can cause a mild hyperkalemia or negligible. And really, when I say mild hyperkalemia, I mean a mild uptick in your potassium level, but probably not enough to even notice. So fluticasone salmeterol, here we're concerned about the salmeterol, long-acting beta agonist. It's going to cause a hypokalemia. It's going to drop your potassium levels. It stimulates a variety of channels, either directly or indirectly, but in general, it does promote potassium influx into cells. So it doesn't reduce your body potassium like furosemide does. It causes potassium wasting. But salmeterol causes you to pull potassium into your cells from your blood. And so that would cause a hypokalemia, even though your body potassium level is staying the same. And then insulin, glargine, or Lispro, they're both insulin, same story. So with insulin, you stimulate a sodium-potassium ATPase, pulls potassium into your cells. So anytime you give insulin, we're worried about the potential of dropping the potassium. So do you want to give insulin to somebody who's got a low potassium? No, you want to correct their potassium first and then give them the insulin. Okay, so there is a list of drugs. Only one of them really causes hyperkalemia. The rest either cause hypokalemia or really don't do much at all. So you want to know some causes of hyperkalemia. Big one, medications. The one you really want to know as far as medications that cause hyperkalemia are ACE inhibitors. And then NSAIDs can do it too, but really not by their own. Usually if you're combining ACE inhibitors with NSAIDs, it's going to make those ACE inhibitors more likely to cause a hyperkalemia. I'm not sure why. It may have something to do with how NSAIDs interact with the kidneys and then how ACE inhibitors then work on the kidneys. But what we're really concerned about is the combination of ACE inhibitors with NSAIDs. Acidosis, either metabolic or respiratory. Cellular destruction, remember your cells are little baby reservoirs of potassium. Each of them are. And so if you have cellular destruction, like from a burn or something, those cells die, they spill out their potassium, and now you have hyperkalemia. I'm not sure if this would also include like tumor lysis syndrome. I imagine it would. Hypoaldosteronism, for reasons we talked about, kind of the same reason why ACE inhibitors would cause hyperkalemia. If you just have a hypoaldosteronism, that would cause hyperkalemia because you don't have enough of a hormone that helps you kick out potassium. Excessive intake. So in this case, we see usually it's in conjunction with renal failure or renal insufficiency. These patients are often told, restrict your sodium intake because a lot of them have high blood pressure too. And so some of them, and I saw a patient like this like about 8 years ago, and he was told, restrict your sodium intake. So he's like, okay, fine. And he went and found this stuff that is like a sodium replacement, but it's really just potassium chloride. And he was sprinkling that all over his food. And this guy's got renal issues. So what happened to his potassium level? Went way up, and he wound up coming in with I can't remember what it was he came in with, but we found his potassium level, and it was like 8 something. So this guy was taking in way too much potassium, but usually you have to have something else going on, like renal dysfunction or something. It would be really hard to kick your potassium level up high just by eating a ton of bananas or something like that. Nephrons is what the N stands for. Here we're talking about renal failure. Very easy to get hyperkalemia with renal failure. That's why these patients have to watch a very, very, very strict diet. And then excretion issues. Primarily here I'm talking about potassium-sparing diuretics. Renal failure we kind of already talked about. They have poor potassium excretion. But potassium-sparing diuretics, if you give that, you're going to impair the excretion. So you got to be careful. Obviously, when we give diuretics, we're worried about hypokalemia. But if you give potassium-sparing diuretics, we've got to be careful not to work too far in the other direction. So that would be a problem with excretion. And here I have the machine here screaming, my potassium is too high. So remember, machine with hyperkalemia. MACHINE. Moving on to question 6, we have a 38-year-old man presenting to the clinic complaining of fatigue and difficulty breathing for the past 2 weeks. He's otherwise been healthy and has no significant past medical history. He denies fever, cough, chills, and weight loss. He immigrated from Bolivia 2 years ago and has received all recommended vaccines. Vitals are within normal limits. Chest is clear to auscultation. Pulse is regular. There's no murmurs. S1 is normal. S2 is split, which is heard on both inspiration and expiration, although it's longer on inspiration. An EKG is performed. Which of the following EKG findings would be most likely to appear in this patient given the findings from the physical exam? A, left bundle branch block, B, right bundle branch block, C, short PR interval, D, ST segment elevation, or E, T-wave inversion. All right, very classic step 2 question here. You want to know what's wrong in this patient, and then it's asking you what would cause what's wrong in this patient. All right, so I'm going to give you the answer now. The answer is a right bundle branch block. So what's unusual in this patient is that he has what's called a persistently wide S2 split. Normally, you can get an S2 split, but it only happens on inspiration. So when you hear an S2, what you're hearing is both the aortic and the pulmonic valve closing. And when you, now normally the pulmonic valve closes a little bit after the aortic valve. When you exhale, they close so close together that you only hear one sound. But when you inhale, the pressure in your lungs goes down and more blood is going to flow into your lungs, and it keeps that pulmonic valve open long enough to where you actually hear 2 S2 sounds, and that's called the S2 split, and that is normal. What is unusual in this patient is that you hear that S2 split on inspiration and expiration. Okay, so here you can see this is the S2, and this is normal here. You hear the aortic valve close first, then the pulmonic valve, and during expiration, you'll hear them so close together that it sounds like one sound. During inspiration, the pulmonic valve closes significantly after the aortic valve, and so you hear the split. This is what we have in our patient. We have so we have the pulmonic valve closing long enough after the aortic valve to where you hear the split, and then during inspiration you also hear the split, and maybe it's a little bit, it's generally longer than with expiration, but you hear it with both expiration and inspiration. And usually what this is due to is some kind of conduction issue that's causing the pulmonic valve to close later. And that's what the right bundle branch block is. Remember that the right bundle branch is going to the right side of the heart. So if it's taking longer for that conduction to get to that part of the heart, it's going to take longer for the pulmonic valve to close. Now with the fixed bundle branch block, it's similar in that you hear the split in both expiration and inspiration, but the closure is the split is roughly the same length, and that's usually associated with an aortic septal defect. And the idea here is that you have the same pressure in both the left and the right ventricles because they share a common output. You have blood from the left going to both the pulmonic and systemic circulation, and the same with the right. And then the reversed is where you hear a longer split with expiration than with inspiration. This is also called a paradoxical S2 split. And this is associated with left bundle branch block. It's also associated with the things that cause left bundle branch block or dilate the left ventricle. So hypertrophic cardiomyopathy, dilated cardiomyopathy, or things that may interfere with the conduction system on the left side of the heart. So something like an MI. Now, what about these other answer choices? So the left bundle branch block, that would cause a paradoxical split. Short PR interval is usually going to be associated with a loud S1. Our S1 is normal here. The ST elevation is going to be associated with an acute MI. This patient does not have that. And T-wave inversions are also associated with MI or myocardial ischemia. Okay, so you think right bundle branch block, you think things that are going to screw up the right side of the heart, and you know your pulmonic valve is there, and the pulmonic valve is what's causing this S2, this persistent S2 split. Okay, question 7. We have a 38-year-old HIV positive woman presenting to the ED complaining of fever, chills, and night sweats over the last 3 days. These symptoms have been worsening and have given way to difficulty breathing and chest pain. Vitals, blood pressure 135 over 90, heart rate 105, respirations 22, temperature 102.8, saturation 92%. Physical exam is remarkable for coarse crackles in the left lower lung fields. Chest x-ray is ordered and reveals patchy consolidation in the left lower lobe. Her CD4 count is found to be 180 per cubic millimeter. Which of the following is the most likely pathogen? A. Mycobacterium avium intracellulare. B. Mycobacterium tuberculosis. C. Pneumocystis carinii. D. Streptococcus pneumonia. E. Isospora belli. Or F. Cryptococcus neoformans. Okay. So our answer to this one is D, Streptococcus pneumoniae. So it's worth remembering that even in HIV patients, the most common cause of pneumonia is the most common cause of pneumonia in everyone, Streptococcus pneumonia. So there are some distractors here, and those are things that we associate in HIV patients with the lungs. And which ones are those? Cryptococcus neoformans, but Cryptococcus neoformans, yes, it can cause pneumonia, but it's usually a more chronic cough and fever. It's not an acute syndrome. But this certainly can happen. It's an opportunistic illness. It can happen in HIV patients, but it's definitely not the most common cause of pneumonia, and it does not fit this clinical picture. The other one that can cause pneumonia is Pneumocystis carinii. Again, not as common, and the picture is a little bit more chronic. Mycobacterium avium intracellulare. This does colonize the lungs, but it does not cause pneumonia. It causes more of a chronic wasting syndrome. Now, Mycobacterium tuberculosis is also more chronic. It will give night sweats, fever, but it's not going to cause difficulty breathing so much and chest pain, only if it becomes disseminated. But again, this is not as common as Streptococcus pneumonia. Streptococcus pneumonia is the most common, so does the most likely pathogen. And Isospora belli does not cause anything lung-related. It causes diarrhea, again, in HIV patients. So remember some of your HIV, AIDS defining illnesses, these opportunistic diseases here. This patient had a count of 180, so she would fall into the AIDS defining illnesses. She's at risk of Mycobacterium avium complex, which was not the right answer, cryptococcosis, which is not the right answer, but these are things that they are at risk for when their HIV count gets that low. So the most important thing that we do for her is get her on antiretroviral therapy, and get her antibiotics for strep pneumonia. Question 8 gives us a 25-year-old woman presenting to the ED complaining of vomiting, diarrhea, and dark urine and malaise over the past 4 days. She denies fever or sick contact. She returned 10 days ago from a weekend-long bachelorette party in Cabo San Lucas, Mexico. Vitals, blood pressure 104 over 70, heart rate 88, respirations 14, temperature 99.8 degrees Fahrenheit. There is some mild abdominal tenderness in the epigastric area and right upper quadrant. Murphy's sign is negative. Scleroicterus is noted. ALT 5,660 units per liter. Total bilirubin. I didn't put a number here. Okay, let's just say the total bilirubin is high. Which of the following is the most likely pathogen? A. Hepatitis A, B. Hepatitis B, C. Hepatitis C, D. Hepatitis D, or E. Hepatitis G. Okay, so our answer here is A, hepatitis A. So this is a relatively straightforward question. I would say it's definitely something you should have gotten. And if you did not, you should definitely go back and review your hepatitis. So hepatitis A is the only one that's going to give you an acute presentation out of all of these. Hepatitis D and hepatitis G you should have eliminated right away. Remember, hepatitis D only happens in pregnant women who already have hepatitis, typically hepatitis B. So it's a super infection. So you should eliminate. Hepatitis G you probably never heard of, and there's a good reason. Even though it exists, it does not cause disease in humans. So D and E should be eliminated right away. And then hepatitis B and hepatitis C you only get from IV drug use, sexual contact, blood transfusions, needle sticks. It's transmitted through blood. So you're not going to get that unless you have those kinds of risk factors. Furthermore, hepatitis B and hepatitis C cause chronic illness, not acute illness. This is somebody who's presenting very acutely. And hepatitis A is often transmitted foodborne, fecal-oral contact, and it's also highly associated with travel to endemic areas, which includes Mexico and a lot of developing countries. So this fits really well with hepatitis A. Hepatitis A also gives you GI symptoms, including the diarrhea and vomiting. And then the dark urine has to do with the fact that there's liver issues going on here. So hepatitis A is an acute viral infection caused by the hepatitis A virus, which is a member of the Picornaviridae family, and commonly presents as fever, abdominal pain, nausea, vomiting, diarrhea, and then your classic liver symptoms like jaundice and sclerolicterus. It's transmitted through the fecal-oral route, unlike hepatitis B and hepatitis C. And unlike hepatitis B and hepatitis C, the incubation period for hepatitis A is very short. We're talking on the order of 10 days to 2 weeks. 6% of cases are foodborne, 10% of cases are contracted outside of the U.S., which sounds like a small amount, but when you consider that not that many people travel outside the U.S., your risk of contracting hepatitis A if you leave the U.S. is quite high. It is common in the U.S., but even more so in developing countries. So some of the risk factors include travel to an endemic region, contact with an infected person, and being a man who has sex with men. Diagnosis, often you can make this diagnosis clinically, but to really nail down the diagnosis, you get a hepatitis A IgM, which is, remember, is your acute initial immune globulin. But like I said, it can often be diagnosed based on the clinical picture in conjunction with the elevated transaminases and bilirubin, and the treatment is supportive. Question 9, we have a 42-year-old man presenting to the clinic for ongoing intractable heartburn and indigestion. He's otherwise healthy and has no significant past medical history. At the last visit 2 months ago, he was told to try a strict gluten-free diet, but this has not improved his symptoms. He's currently on daily omeprazole, but continues to have symptoms. He is referred to a gastroenterologist for an EGD, which reveals nonspecific gastritis. Biopsies are conclusive for low-grade mucosa-associated lymphoid tissue lymphoma, or MALT lymphoma, and the presence of H. pylori. Which of the following is the most appropriate management at this time? A. Cyclophosphamide, doxorubicin, vincristine, and prednisone. B. Cyclophosphamide, doxorubicin, vincristine, and prednisone plus radiation therapy. C. Radiation therapy alone. D. Omeprazole, amoxicillin, and clarithromycin. Or E. Observation and repeat EGD in 6 months. All right, so our answer to this one is D. Omeprazole, amoxicillin, and clarithromycin. So this is straightforward, but it does require you to know something relatively not so well known, and that's the treatment for low-grade MALT lymphoma. So the treatment for low-grade MALT lymphoma that is H. pylori positive is triple therapy. So triple therapy is what we do for anyone with H. pylori. Remember, H. pylori is causative of ulcers, and this guy may have ulcers too. But anytime you have a patient who's symptomatic and has H. pylori, and usually you only discover H. pylori if the person's symptomatic, you give them triple therapy. Now, yes, this guy does have cancer, essentially. However, what we find is that if you treat the H. pylori, and the person has low-grade malt lymphoma, if you treat the H. pylori, this will often go away on its own. So our first step, if it's low grade and it's associated with H. pylori, is to do the triple therapy. And if that doesn't work, then you can go ahead and do chemo. But this is our first step. Now, if this were a high grade malt lymphoma, then you would go to chemo. If this were not associated with H. pylori, well, then triple therapy wouldn't work, so you'd go to chemo. And you can also do radiation in conjunction, but you don't need to know that stuff for USMLE. What you do need to know is that the treatment for malt lymphoma, and if you get it on the USMLE, it'll always be low grade and associated with H. pylori. The treatment is the triple therapy. So malt lymphoma is a B-cell lymphoma arising from mucosal-associated lymphoid tissue. 90% of cases are in the stomach and are associated with chronic H. pylori infection. The median diagnosis is 61 years, so this is an older age thing. Risk factors, obviously H. pylori infection, autoimmune disease, just simply because of the activation of the immune system in those B cells. Age over 60 years, female, and HIV positive. Remember, HIV is associated with a lot of different cancers and lymphomas. Symptoms include epigastric discomfort and indigestion, pretty nonspecific. So anytime you have a patient with protracted epigastric discomfort and indigestion that doesn't go away with your classic treatments like antacids and trying a gluten-free diet, you should get an EGD, get biopsies, and that's going to yield your definitive results. You should get a CBC on patients who have long-term GI symptoms. You want to check to make sure there's no bleeding. You would find anemia and thrombocytopenia here. There may be some bleeding in this patient because he may have an ulcer, but the anemia and thrombocytopenia can also be caused from the lymphoma. So you can have, you may have an iron deficiency anemia here. If there's bleeding, you may have an anemia of chronic disease here because of the lymphoma. Thrombocytopenia would be a potentiality as well. H. pylori serology or stool antigen test could be done, especially if you're suspecting an ulcer. If you do that, H. pylori will often come back positive in a patient with malt lymphoma because, remember, 90% are associated with H. pylori. The treatment, as we already talked about, if it's low-grade and H. pylori positive, you'll start with triple therapy, repeat the EGD and biopsy after 2 months, see if it's gone away. If it hasn't, then we consider it to be resistant to triple therapy, and then we start in with chemo and possibly radiation. But most of these cases will resolve with triple therapy. All right, and then we'll finish up with question 10. We have a 32-year-old woman presenting to the clinic complaining of 3 days of progressive right-sided facial weakness. On physical exam, it reveals significant findings as seen in the figures here. Which of the following is the most likely diagnosis? A. Bell's palsy, B. Ramsay-Hunt syndrome, C. Horner syndrome, D. Trigeminal neuralgia, or E. Varicella, also known as chickenpox. So I'll give you some time here. Here's your clinical findings, and this you have a painful ear. All right, so our answer to this one is Ramsay-Hunt syndrome. So this you got to know. You got to know about Ramsay-Hunt syndrome because if you get a question on Ramsay-Hunt syndrome on the USMLE, it's going to be very straightforward and it's an easy point. So Ramsay-Hunt syndrome is associated with herpes virus, I should say, which in particular it's the human herpes virus 3, which is also known as the varicella zoster virus, which is the virus that causes chickenpox. This is really just, you can think of Ramsay-Hunt syndrome as a shingles of the facial nerve. So really that's all it is. And it tends to affect the ear area. It also gives you this ipsilateral facial weakness, and it looks a lot like Bell's palsy. The big difference is that you have this ear pain and these vesicles that show up on the ear. So it's kind of like Bell's palsy meets shingles, but it really is more like shingles based on the causative agent. So you might have looked at this and said, oh, Bell's palsy, because look at this patient's face. And it does look a lot like Bell's palsy, but the distinguishing factor here is these vesicles and the pain around the ear. Horner syndrome, remember, it affects the oculosympathetic nerves, but it has a triad of ptosis, meiosis, and anhidrosis. So you're not going to have this stuff on the ear, and you're not going to have any weakness in the lower part of the face. It's only going to be around the eye, and you would notice unusual pupils. Trigeminal neuralgia is a chronic pain syndrome and affects the trigeminal nerve. These patients will get paroxysms of pain on the face. They're not going to have anything like this going on around the ear, and they're certainly not going to have any kind of weakness in the face. It's solely pain. And then varicella, you're going to have a generalized rash. So you get very similar looking lesions, but they're generalized over the whole body. And then again, you're not going to have this weakness in the face. So Ramsay-Hunt syndrome, it's basically just an acute peripheral facial neuropathy, and it's characterized by these erythematous vesicular rash, and that's on the skin, in the ear canal, on the auricle, or on the I don't have a picture of this, but it can be in the mucous membranes as well. But it's all ipsilateral. It's only going to be on one side, because remember, it's a shingles-like illness. There's also accompanied ipsilateral facial palsy, so everything's going to be on one side. And this is a lower motor neuron facial palsy, so it affects the entire side of the face. It is caused by varicella zoster virus, also known as HHV3. This is the virus that causes chickenpox, so very similar to shingles. The classic triad is ipsilateral facial paralysis, vesicular eruption in and around the ear, and ear pain. It doesn't always have this facial paralysis, though. So if you ever see this shingles-like pattern around the ear, it could easily be Ramsay-Hunt syndrome. But facial paralysis is common. I imagine they will give you the facial paralysis on the USMLE because they're probably going to give you a pretty classic case of Ramsay-Hunt. Diagnosis is clinical, just like how you diagnose shingles. The treatment is generally corticosteroids and acyclovir. There's some people that say that it doesn't really help the course of the illness, but then there's also studies that say if you delay treatment, it may result in permanent hearing loss, which is a complication of having these vesicles in and around the ear. So you're better off just doing this treatment. And usually it will resolve spontaneously, but it may take months. And that stands in contrast to Bell's palsy, which typically resolves in a few weeks. Ramsay-Hunt syndrome can take a little bit longer than that. And I think it's like 50 to 70% of cases resolve within a few months. Okay, that's all I've got for you. I will see you next time.